Hello, welcome to the Basics of Coding and Billing webinar. We will answer questions at the end of the webinar. To submit a question, please type it into the question pane. Please welcome coding expert Cecile Katzoff, Vice President for Consulting Services at the AGA Institute.
Hello everyone. I'd just like to preface this presentation by saying that this is not a comprehensive coding and billing seminar. This is meant to give you the basics of coding and billing, and if you are interested in getting a more in-depth education on the subject, I suggest that you consider attending the McVeigh seminars. You can get a list of their seminars and locations at McVeigh.com. Or I would be very happy to come to your practice and give an in-depth session to your physicians and staff. And if you are interested, please contact me at ckatzoff@gastro.org, or you can call me at 301-941-2639. We will begin. Why is it so important to know the principles of coding and billing? First of all, there are a lot of audits going on right now. Every service that you submit to an insurance carrier, and that's not just Medicare or Medicaid, but the private insurance companies as well, are being reviewed to determine whether they are correct. The Inspector General of the Department of Health and Human Services, or the OIG, has targeted specific types of services as being problematic. The first is Incident to billing, and we'll talk about that in depth. Second is screening colonoscopies, those that are billed as screening when in fact they are not screening by definition, or services that are not screening and billed as screening. Place of service errors, those are services submitted primarily with place of service office. That is number 11 as place of service, when in fact the service was provided in a hospital location. And consultations. Now, consultations are no longer payable by Medicare. However, the OIG is still looking back on services billed as consultations in the prior years to determine whether they were billed correctly. We also have the recovery audit contractors. These are private contractors that are working for CMS, or the Center for Medicare and Medicaid Services, and they are looking at specific issues like services billed with a diagnosis for iron deficiency anemia when in fact there is no documentation in the medical record to support the fact that the patient does in fact have iron deficiency anemia. They are looking at incorrect diagnoses codes that are being billed for services. They are certainly looking at levels of service to determine whether the documentation supports the level of service. And again, they are also looking at services billed as consultations that either do not meet the definition of a consultation or do not have the documentation to support the billing for consultations. We're going to start with evaluation and management services, and we are going to talk about consultations because at this point in time there are insurance companies that are still billing for consultations, so it's important to know what the definition of a consult is. So these are the CPT definitions. CPT, Common Procedure Terminology, that is published by the American Medical Association, and it is basically the Bible of coding for services used by all payers. A consultation, which is codes 99241 to 99245 in the office and 99251 to 99255 in the hospital, is a service requested by another physician or non-physician provider. The service is for an evaluation and opinion regarding a problem and requires a separate letter back to the requesting physician or non-physician provider for services performed that are not in the hospital where you have a common medical record. Consultations are not restricted by time. You can, for outpatient services, those services performed in the office or outpatient department of the hospital, If you have a request for an evaluation and opinion and you bill a consultation, and a few months later you have another request from the same physician or source, even for the same problem, to evaluate the patient for that problem, you can again bill it as a consultation. For inpatient consultations, you can only bill one per admission. A new patient visit. These are CPT code 99201 to 99205 and apply to services provided in the office or any outpatient hospital location. This is a service that is either self-referred, in other words, the patient initiated the service, or the patient was referred to the practice for a procedure because they have some symptoms and you see the patient prior to the procedure. That service is a new patient visit. It is only billable once every 3 years, so if anyone in your practice has seen the patient and provided any face-to-face service to the patient in any location for any reason, when the patient returns to the office within that 3-year period, you cannot bill a new patient visit. It is only billable once every 3 years. An established patient, CPT 99211 to 99215, is any patient that has been seen in the office within that 3-year designated period for any reason by anyone in the practice who's of the same specialty that I did mention earlier. It has to be someone of the same specialty designation. And for gastroenterology, there is only one specialty designation. So even if you are a subspecialty within gastroenterology, that is still considered the same designation, and the 3-year period would apply. Effective January 1st, 2010, Medicare eliminated the consultation codes. So the first time you see a patient in the hospital, rather than billing it as a consultation, you would bill it as an admission code or the initial hospital care code, which is 99221 to 99223, assuming that the documentation in the medical record supports a minimum of a 99221. If it does not support at least a 99221, you can bill the subsequent hospital visit codes, which are 99231 to 99233. Services provided in the emergency room. These are for Medicare patients, and for anyone who has eliminated the consultation codes, you can bill the emergency department visit codes, which are 99281 to 99285. A service provided in an observation unit, you would have to bill it as an outpatient, or the same codes that you would use in the office, whether new or established. Again, you must meet the definition of a new patient in order to bill for the new patient codes. So if you've seen the patient in the office or any other location prior to seeing them in the observation unit, you can only bill an established patient visit if it's within 3 years. Observation codes themselves are restricted to a patient who is in a condition that may be admitted or may be discharged, but it can only be billed by the physician who would ultimately admit the patient to the hospital if the patient requires admission. It also is very specific in terms of the documentation requirements, and it is not likely that a gastroenterologist would meet both the definition and the documentation requirements. So that's why you would bill it as if it were an outpatient department of the hospital. The levels of service for the evaluation and management codes. For consultations and outpatient services, there are 5 levels. For inpatient services, there are 3 levels. The levels of service are determined by the extent of the history, the examination, and the medical decision making. but it is the medical decision-making that will drive the level of service. So regardless of whether you have a comprehensive history and a comprehensive examination, if you do not have a high level, or at least a moderate level, of medical decision-making, you will not be able to bill a high level of evaluation and management service. So it's really medical decision-making or diagnosis-driven. If you have a nurse practitioner or physician assistant working in your practice, they are not restricted to any category of service or any level of service, and we'll talk a little bit more about that later. Another option when selecting the level of service is the counseling or coordination of care option. If more than 50% of the total face-to-face time between the provider and the patient is spent in counseling or coordination of care, you can select the level of service based on the total face-to-face time. In the CPT book, at the end of each definition for the evaluation and management services, there is a time component listed. You must at least meet that time component in order to select that level of service. The documentation for the counseling option is you must indicate the total amount of time, how much time was spent in counseling and or coordination of care, and what was discussed during that time. Okay, a little assistance in selecting the level of service. Now you can look at the documentation guidelines. There are both 95 and 97 guidelines. They are on the CMS website, but they are quite confusing and difficult to follow. So I'm trying to give you a few hints in determining the level of service. For a level 4 and 5 E&M service, that's both new patient and consultation, you must have a comprehensive history and a comprehensive examination. The medical decision-making for a level 4 is moderate, and that would be a patient with a new problem, new to you, not necessarily new to anyone else, but new to your practice, and that patient is scheduled for an endoscopy, and the patient is otherwise healthy. That same patient with an acute or chronic illness that poses a threat to life or bodily function, or an undiagnosed new problem who is scheduled for an endoscopy and has identified risk factors that makes them high risk, that patient would then move up to a level 5. So again, you need a comprehensive history, a comprehensive examination, and for moderate medical decision-making, the patient who is otherwise healthy and scheduled for an endoscopy, that would be a level 4, new patient or consultation. And for the patient who is considered high risk, that would be a level 5, new patient or consultation. Okay, again, you must meet or exceed all 3 levels of the history, the examination, and the medical decision-making in order to select that level of service for either consultation or new patient visits. So all 3, if you have different levels for each of the 3, you can only select the lowest level of the 3 for a consultation or a new patient visit. For an established patient or subsequent hospital visit, you only need 2 out of the 3 components. Now, one of those 2 should be the medical decision-making. Okay? So for a patient who is seen in the hospital or a patient who returns to the office within the 3-year period, you can reference the history taken during the initial encounter. If it's in the office, usually the patient completes a history form. And as long as that form is signed and dated and includes all of the components of the review of systems and past family and past social and family history, you can reference that form each time the patient returns to the office by saying something like, for ROS and PFSH, see form completed by patient and the date it was completed, and get full credit for the history, as long as you have the chief complaint. In the hospital, usually there is an admitting history and physical that is done and in the chart. And again, if you want to reference that history for the review of systems in the past family and social history, you can do that by date it was completed and by whoever completed the form, and you get full credit for the review of systems in the past family and social history. So again, you need a chief complaint, but for the remainder of the history, you don't have to repeat it. You can just reference it. Certainly, if there are any changes since the initial history, you need to note those changes, but again, then say everything else would be the same as the form completed during the initial encounter. This is the history guidelines. For a problem-focused history, you would need 1 to 3 elements of the history of present illness. You do not need a review of systems, and you do not need a past family and social history. For an expanded problem-focused history, you need 1 to 3 elements, you need 1 system, and the review of systems. For a detailed, you need 4 or more elements of the present history of present illness, and that would be, the history of present illness would be items like timing, duration, severity, modifying factors, and the like. For a review for the detailed, you need 2 to 9 systems documented. And by the way, the review of systems it's not sufficient to say all other systems negative. You must list all of the systems where you asked questions of the patient. If you don't have a document in the chart where those questions are documented, and you must indicate whether there are any problems with any of those systems. And for the past family and social history, for a detailed history, you would need 1 item from each of the 3 areas, which would be the same for a comprehensive. So for a comprehensive, the difference between a detailed history and a comprehensive history is that for a comprehensive, you need to have documentation of 10 systems reviewed in your review of systems. For the examination, for a level 1, you need to examine in the 95 guidelines 1 organ system, which means you have to have a question within that organ system. In the 1997 guidelines, they're based on bullets. You would need 1 to 5 bullets. For a level 2, you need to have examined or have a question answered regarding an examination of 2 to 4 systems. And again, in the 95 guidelines, that need only be 1 question. For example, for a cardiac system, you could have a question of regular rates and rhythms and say normal or abnormal. If you list it as normal, that's all you need to do is check that off. If it is abnormal, you need to indicate what it was that is abnormal. And in the 1997 guidelines, you need to document at least 6 bullets. For the level 3 new patient or consultation, you need to have 5 to 7 organ systems documented and 12 bullets for the 97 guidelines. And level 4 or 5, 8 to 13 organ systems documented and 2 bullets from 9 organ systems for the 97 guidelines. I would suggest that you concentrate on fulfilling the 95 guidelines because the 97 guidelines do not have a gastrointestinal examination, so your only option would be to use the general multi-system exam. The 95 guidelines are easier to document. Again, all you need to have is 1 item within each organ system. Have it listed as either normal or abnormal, and if you identify it as abnormal, you need to indicate what it was that was abnormal. Now, unfortunately, what I see in audits is there are body areas that are identified but not organ systems. For example, abdomen is a body area. It is not considered an organ system. Gastrointestinal is an organ system. And if when I audit, I look not only for an examination of the abdomen, but some reference to a rectal exam. You don't have to do it, but you need to reference it. You need to say either that it was deferred or if you did do it, what the results were normal or abnormal. The same would apply to head and neck or extremities. Those are not considered organ systems. Those are considered body areas. So if you take a look at the documentation guidelines, you will see what is listed as an organ system. And in order to bill a level 4 or 5, either a new patient or consultation, or a level 2 or 3 initial hospital visit, you need to document at least 8 organ systems, at least one item within each of 8 organ systems. The medical decision making. It is comprised of 3 components: the presenting problems, diagnostic testing ordered, and table of risk. In the table of risk, you need to have 2 of the 3 components in order to determine that level of medical decision making. So here's the table of risk. For a level 4 new patient or a level 2 initial hospital visit, you would have to have a prescription drug management or IV fluids with additives. If you look at the level 5, for a treatment plan, you have diagnostic endoscopy with no identified risk factors, which is the center column. Okay, for a level 5, notice it has diagnostic endoscopies with identified risk factors, and the other option, which is often the case in gastroenterology practice, which is on the right-hand column, the second bullet, drug therapy requiring intensive monitoring for toxicity. So this would apply to your patients who are on Remicade infusions, or your hepatitis patients who are on some kind of treatment that is considered highly toxic and has to be monitored very closely. That would put them in a high-risk category, and if you have a comprehensive history, you could bill that as a level 5 new patient, established patient, hospital admission, or hospital follow-up, subsequent hospital visit. Selecting the level of service. If you take all of those components and put them together, the 99201 and the 99241, you need a problem-focused history, problem-focused examination, and straightforward medical decision-making. And notice the column on the right, these are the time components that I mentioned earlier out of the CPT book, where you can select the level of service based on counseling or coordination of care, as long as the total face-to-face time meets or exceeds these time components, and more than 50% of the face-to-face time was spent in counseling and coordination of care. 99202 or 99242 requires an expanded problem-focused history, an expanded problem-focused examination, and straightforward medical decision-making, and total time of over 20 minutes. Now again, the time component only applies if you're selecting the level of service based on the counseling or coordination of care component option. It does not apply when you are selecting a level of service based on the history, examination, and the medical decision making. There is no requirement for spending any minimum amount of time with the patient when you have that documented. For a 99203 or a 99243, excuse me, you need a detailed history, a detailed examination, and low medical decision making. 99204 and 99244, you need comprehensive history, comprehensive examination, and moderate medical decision making. And level 5, you need the same with high medical decision making. Again, the documentation is what's going to drive this, and the medical decision making is really what determines the level of service. For an established patient, you only need 2 out of the 3 components. For 99211, actually that is a nurse's visit. There is no requirement for a physician to see the patient. A physician provider is present. Service can be documented by the nurse, but it does require the documentation for an evaluation and management service that is separate from any procedure that is being done or therapy that is being done for the patient. So for example, if the patient is given an injection by a nurse, the injection is what is billable. You would not bill a 99211. 99212 is problem-focused. History examination and straightforward medical decision-making. 13 is expanded problem-focused. History exam and low medical decision-making. 14 is detailed history exam and moderate medical decision-making. And 15 is comprehensive history and exam and high medical decision-making. So for example, if you have a patient that presents who is a hepatitis C patient who is on pegentron, which puts them in a high medical decision-making category, and that you have a comprehensive history but a detailed or even no examination at all, you can still bill that as a 99215 because you only need 2 out of the 3 components for an established patient visit. For an inpatient service, 99221 to 99223 all require a comprehensive history and examination. So the only thing that really changes here is the medical decision making. And given the fact that patients are normally not admitted to the hospital unless they are very sick, it is likely that the medical decision making will be high. Most of the patients will have multiple problems, will have underlying conditions that affect their treatment, particularly those patients that you do schedule for an endoscopy. Those usually end up being a 99223, assuming that you have documented the history. Again, you can reference the review of systems in the past, family, and social history if it's in the chart documented by someone else. And you do a comprehensive examination of one item within 8 systems. You can bill that as a 99223. For a subsequent inpatient visit, you need 2 out of the 3 components. Again, we could have a detailed history without much difficulty by referencing the history that was done previously. And again, if the patient is very sick, you would have high medical decision making. What most payers expect is that when the patient is first admitted to the hospital, they are very sick and therefore require a high level of service. And one of 2 things happens during the course of their admission. They either get better or they die. If they get better, you will likely see the levels of service decreasing until they are discharged. Of course, there's a possibility that they may have a severe episode during the admission, and then the level of service will increase. What you should not be doing is billing the same level of service every time you see the patient. Make sure you vary the level of service based on the intensity of the problem you're dealing with and the patient's response to treatment. And generally, when the patient is ready to be discharged, there'll be a level 1. Do not bill level 1s for every day they're in the hospital. Billing the same level of service, whether inpatient or outpatient, continually will send up a red flag to the payers. That what they're going to imply is that you are not paying attention to selecting the appropriate level of service, and it may trigger an audit. So make sure you vary the level of service based on the problem that you're addressing and the status of the patient in terms of how sick they are. For inpatient consultations, you would have the same requirement as outpatient consultations in terms of selecting the levels of service for the documentation of the history of the examination and the medical decision making. Again, the assumption is that the patient is admitted to the hospital, they are very sick, which probably would put them either in a level 4 or level 5 status, assuming you have the appropriate documentation. Here are some pointers relating to documentation. It must be legible. If you cannot read it, or if I cannot read it, or any auditor who is reviewing the chart cannot read it, then there was no service being provided and nothing is billable. You can use templates, and I highly encourage you to use templates. If you're not already on an electronic medical record, you should create some templates for yourself, or you can purchase the templates that are available through the AGA, which are the history and physical intake forms. They make the documentation process much easier. It makes someone reviewing the medical record have a much easier time in finding the information that they need to support the level of service. Every service must have a chief complaint. So even if you're seeing the patient for the 30th time for the same problem, the first thing that I should see when I look at the documentation for that date of service is why you are seeing the patient that day. Follow-up is not a chief complaint. Follow-up to what? What was the original problem? What are you seeing the patient ongoingly for? That would be the chief complaint. Without a chief complaint, there is no billable service. New patients and consultations must have a history of present illness. As I mentioned earlier, that would be duration, timing, severity, associated signs and symptoms, and mitigating factors. All of those are components of a history of present illness, and if you have 4 of those, you have an expanded history of present illness. You can document that in one sentence. For example, patient presents with lower right quadrant abdominal pain, persistent over the last 4 weeks, exacerbated after eating, and alleviated by taking an over-the-counter antacid. That would comply with all of the 4 components of the history of present illness. The review of systems and the past family and social history may be documented by anyone, including the patient. It has to be signed and dated by the provider and then referenced in your documentation. The examination can be listed with normal and abnormal, and any item that is listed as abnormal must be explained. So again, you have to have, for the 95 guidelines, you have to have 1 area examined within each of 8 systems to meet the documentation requirements for a comprehensive examination, and you need to indicate whether that was normal or abnormal and explain anything that was abnormal. When using the counseling option to determine the level of service, you must document the total face-to-face time between the provider and the patient, how much of that time was spent in counseling or coordination of care, and what was discussed during that time. This is an option that is very applicable. For example, the patient who has had an endoscopy and returns to the office to go over the results, to talk about any treatment options, lifestyle changes, diet changes. There may not be a repeat of the history. There may not be an examination that takes place during that encounter. You can select the level of service based on the total face-to-face time with the patient. There is no requirement in the documentation guidelines. Well, I shouldn't say that. I don't know why I have that. No requirement for physician signature. That is incorrect. You must sign and date the history completed by the patient in order to use that for the documentation in your to select your level of service. The visit preceding a screening colonoscopy. We're going into some of the regulations here related to some of the services that you may provide. For those practices that have a policy of seeing the patient prior to performing a screening, meaning a screening by definition means the patient has no symptoms or the symptoms are not significant enough to support a diagnostic colonoscopy, and you have no findings on examination. If you choose to see the patient prior to the scheduling the procedure, you can only bill a preventive medicine service. It is not billable as any other evaluation and management service because you do not have a chief complaint and you do not have a history of present illness. Medicare does not pay for preventive medicine services, so it will be the patient's responsibility to pay, and you do not need an advance beneficiary notice because it is a non-covered service under the Medicare program. Private insurers will pay for one preventive medicine service per year per patient. If the patient has just been seen by their primary care physician for their annual checkup, it's likely that they have billed the preventive medicine services. So if you submit the claim to the private payer, you will likely get a rejection, and again, it will be the patient's responsibility to pay. For patients that have a high-risk condition that requires physician intervention, for example, the patient who is on Coumadin, you can see the patient prior to the procedure. You would bill it as either a new patient or established patient visit if you've seen the patient within 3 years. And the diagnosis to support that visit would be the diagnosis for the high-risk condition that requires intervention. Now, it must be a patient who is on prescription medication or a patient who is taking insulin, for example, diabetic and taking insulin. It would not be appropriate for a patient who is taking aspirin or anything over the counter that has to be held prior to the procedure. Diagnosis coding. Even though you get paid based on the CPT code that you submit, whether or not you get paid is almost entirely determined by the diagnosis code submitted with that service. The primary diagnosis submitted with the service is always the reason for the encounter. Why is the patient being seen today? Be careful not to refer to a prior diagnosis that no longer supports today's service. It has to be the reason for today's encounter. The secondary diagnosis would be an underlying condition that affects the treatment that you're prescribing to the patient or their response to treatment. For example, if the patient presents with GI bleed and that patient is also diabetic, the primary diagnosis would be the GI bleed. The secondary diagnosis would be diabetes. If the patient presents with multiple GI symptoms, the primary diagnosis would be the most severe of those symptoms, and then you would go on from there. The primary diagnosis is very important. If the diagnosis does not match the service that's being billed, you will get a rejection, even though it may appear later in the list of diagnoses. So the primary diagnosis must support the service that is being billed. You have to code to the highest specificity, meaning that if there is a fourth or fifth digit available, ICD-9 codes come in 3, 4, and 5 digits. If there's a fourth or fifth digit available, you must code it to the fourth or fifth digit. You never code the diagnosis if you are not sure yet by supporting documentation that the patient actually has that diagnosis. So you never code rule out or suspect. If you don't yet have a definitive diagnosis, you would code the symptoms until the diagnosis is confirmed. The V codes in the ICD-9 book are for either healthy conditions or for family history or personal history of a disease or disorder. You would only use V codes for preventive medicine services or for a screening procedure. You would never use a V code to support any other evaluation and management service. So if the patient presents with multiple problems, or if the patient presents with, let's say, upper GI problems, and you're going to be doing an upper endoscopy, but the patient is also 50 years old and has not yet had a screening colonoscopy, for that visit, you would only use the symptoms for which you're going to be performing the upper endoscopy. You would not use the V code for a screening colonoscopy. The V code is only used for the procedure itself, not for the evaluation or any evaluation and management service. Always link the diagnosis with the procedure or service. If you have multiple procedures and multiple diagnoses, you must identify which diagnosis goes with which procedure by numbering them, so you would have corresponding numbers next to the procedure code and the diagnosis code. If you have multiple diagnoses, list them in order of severity, so whoever enters the information into the computer system will know which is the primary diagnosis. An advanced beneficiary notice, or ABN, is required by Medicare for any service that may be denied as not medically necessary. It cannot be given to every Medicare patient every time a patient is registered in your office. It must be given only to those patients who are scheduled for a service or considered for a service that may be denied as not medically necessary. It must be completed and signed by the patient before the service is rendered. And in a GI practice, the most likely service that would require an ABN would be a screening service where you don't know, if you don't have documentation, when the patient had their previous screening procedure. Then I would suggest you get an ABN signed so that the patient understands that if it's within the time restriction, that the patient is responsible to pay. If you do not get an ABN signed and the service is denied as not medically necessary, you cannot bill the patient. Coding for endoscopies. The appropriate family of codes are esophagoscopy, EGD, enteroscopy, sigmoidoscopy, colonoscopy, and ERCP. You would code each procedure within each family. Everything that you do, code it. There are some codes that are bundled one into the other, but if you are doing them on different sites or different lesions, they are separately billable. The diagnostic code within each family can only be billed by itself. It cannot be billed with any other code within that same family of codes. Code all abnormal findings. If you do not have an abnormal finding, code the symptom to support the procedure. If multiple procedures and diagnosis are done, make sure you link the diagnosis with the procedure. If the patient is scheduled for a screening, so they come to your office expecting to have a screening colonoscopy, and you find a lesion and you either biopsy it or remove it, the primary diagnosis is still the screening. That this differs from any other type of service. So when the patient presents for a screening, regardless of the findings, the primary diagnosis is always the screening, and the second diagnosis would be the polyp. The way to bill that is to enter the procedure code, and on the line with the procedure code in box 24E, which is the diagnostic pointer box, you would put a number 2, linking the procedure with the diagnosis for the polyp. Bundled codes, if there is one code that defines the entire package, you have to use that code. When you are removing polyps, if you're using one method, you can only bill that code one time regardless of the number of lesions. If you are using multiple methods for removing different lesions, you can code each method. You need a 59 modifier on several, either on one of the two polypectomy codes, or if you're using cold biopsy forceps, you need a 59 modifier on the biopsy code. When you're using multiple methods to remove one lesion, the same lesion, then you can only use one code to bill for that service, and you select the most intense of those codes. So let's say you take a piece off using cold biopsy forceps, but then you remove the entire or destroy the entire lesion with an ablation using argon plasma coagulator. You would build the ablation code for that service. For control of bleed, it's only billable if the patient was bleeding before you went in. If you caused the bleed by doing a biopsy or removing a polyp, control of bleed is not billable. If the patient was bleeding from one location and you remove a polyp and do a biopsy from another location, you can bill the control of bleed with the 59 modifier in order to get paid for both. The screening codes are G0104 for flexible sigmoidoscopy, which is billable every 48 months for patients over the age of 50. G0105, which is colonoscopy for a high-risk patient, billable every 24 months. And G0121, which is colonoscopy for average-risk patient, which is billable to Medicare every 10 years for patients over 50. To document procedures, make sure you include the indication, why are you doing the procedure, what were the symptoms that the patient presented with, make sure you identify which orifice was entered, how far did you advance the scope, what did you view while advancing the scope, any procedure that was done during that endoscopy, what were your findings, and what are your plans for treatment. Okay, we're at the end of the presentation. We have some time for questions. If you haven't already done so, please enter your questions into the question box. Okay. Okay, we have a few questions, and I have to be able to see them. Okay, we know of a general surgeon who bills 45384 on 4 separate lines and is getting paid by Medicaid. What do you think? I think that, I hope he looks good in stripes. That is definitely unbundling. You can only bill one code for the same method regardless of the number of lesions. Okay, next, can we print this presentation? I don't know. Actually, the presentation will be up on our website within a week. So if someone in your practice did not have the opportunity to listen to the presentation or view it, you can view it on our website, and I'm sure that you could probably print screens from the website. Okay, an established patient visit, which requires 2 of the 3 components. If the 2 are history and examination but not medical decision making, what code would you assign? I believe you said one should be the medical decision making. Yes. You have to have medical decision making when billing for any evaluation and management service. If you do not have medical decision making, you really do not have an evaluation and management service. So at least one of the two components for an established patient visit must be the medical decision making. What do you consider prescription drug management? A physician only addresses one drug, would you use as prescription management? Yes. As long as the patient is on a prescription medication and the physician is the one who is prescribing it or managing it, then you can use prescription drug management as one of the components of the medical decision making. If the note says only follow-up or RX refill, would no code, would this service be billable? It would not. Again, you need a chief complaint for every service that is provided. So you would need to indicate what the follow-up was for or what the drug refill was for in order for the service to be billable. Follow-up or RX by itself, RX refill by itself would not generate a billable service. Can we get a copy of this presentation emailed to us? Again, the presentation will be available on our website within a week, and you can view it from there and listen to it from there. Okay, gee. What about EUS codes? Endoscopic ultrasound is a technique used to evaluate the colon and the digestive tract. There are a number of codes for endoscopic ultrasound in all of the endoscopy sections. I suggest you take a look at the CPT book and you will find the endoscopic ultrasound codes. Again, they are by the type of endoscopy and what was viewed under the ultrasound to select the codes. And the sonography is included in the code. It is not separately billable. If I bill an ER visit and so does the ER physician, will we both be paid? If it's a Medicare patient, yes. Under the current system, there is no restriction on how many physicians can bill an ER visit. As long as the patient is in the emergency room and you see the patient there, you can bill for the emergency room service. Endoscopic mucosal resection, where we have to inject, use a snare and APC. When you're billing for endoscopic mucosal resection, you would bill the method used to remove the lesion or destroy the lesion. So if you're using plasma coagulator to destroy the lesion, you would bill an ablation. If you're using some type of an injection, you would bill the injection code, but there is no separate code for endoscopic mucosal resection. How do you bill for a peg removal when you're not the physician who placed the peg? If you're removing a peg manually, it's a in your office, it's a visit. If you are removing the peg endoscopically, then it's a removal of foreign body. But there is no separate code for removing a peg manually. It would just be an evaluation and management code. What if the patient comes in with poor prep and you have to abort the procedure and have to reschedule? How do you bill? If you start the endoscopy and you find that the patient has a poor prep, if it is a screening or diagnostic colonoscopy, you bill the procedure with a 53 modifier. If it is any other procedure, so if it's a colonoscopy with biopsy, for example, or polypectomy, you use the 52 modifier. The 53 modifier for a screening will allow you to repeat the procedure within the designated or restricted time period. Without the 53 modifier, you will not be able to rebuild the procedure and get paid for it within the restricted time period. How do you bill an E&M visit for a patient who had a cancerous polyp 5 years ago and is back for a repeat colonoscopy? That would be a high-risk screening with a diagnosis of personal history of malignant neoplasm of the colon, which would be a V code, and you can do that procedure if it's a Medicare patient, every 2 years. Is the E&M code billable prior to doing that screening colonoscopy? No, it is not. Again, you have a patient that does not have current symptoms. You're going to be doing another screening colonoscopy on that patient. So the evaluation and management service, if you choose to see the patient prior to the procedure, is not billable, again, unless the patient has an underlying condition that requires the intervention of the physician. If that would be the case, if you've seen the patient 5 years ago, you can bill a new patient visit. If you've seen the patient within the last 3 years, it would be an established patient visit. Our doctor wants to do a paracentesis in the office. What codes are billable? Anything else such as an albumin if given? That is a more detailed question, and I would suggest you contact our coding and billing answer line so that I can investigate the specific codes and I can give you a response at that time. Again, the email for that is GI Coding and Billing Answer Line at gastro.org. You can email me and I will give you the answer to that specific question. If the patient is scheduled for a screening colonoscopy and on day 1 endo, when the patient is identified with rectal bleed and GERD, can I bill for the history and physical? If you see the patient prior to scheduling the procedure, and during that evaluation you identify GI problems that you are going to treat, or a GI problem that would justify a diagnostic colonoscopy rather than a screening colonoscopy, you can bill for that visit using either the new patient or established patient codes, depending on whether the patient was seen within the last 3 years. If you are not planning on treating those conditions, then that visit would not be billable. If you see the patient immediately prior to the procedure, so the patient is already prepped, either in your office or in the endoscopy suite, that history and physical is not separately billable regardless of what you identify during that encounter. That history and physical is considered bundled into the procedure. If we perform procedure in a surgical center, then see a patient in the office within 3 years of the procedure, can we bill an initial office visit? For a Medicare patient, you cannot. If you have provided any face-to-face service, or I can modify that to any face to any other body part, you cannot bill a new patient visit as long as that service was within the last 3 years, regardless of the diagnosis. So even if it's for a totally different problem and you have never seen that patient in the office, as long as you've provided the service to that patient in any location, when that patient presents to your office within 3 years, that is an established patient visit. A surveillance colonoscopy done for a history of polyps but no current symptoms and screening for colon cancer, what should be the primary diagnosis? If the patient has had a previous colonoscopy and has been identified as having polyps, or a patient who has a family history of colon cancer or polyps, that is the primary diagnosis. You would not use the V76.51 as primary. You can use that as secondary, but the reason for the procedure is, the reason for the frequency of the procedure is because the patient either has a personal history of polyps or a personal history of colon cancer or family history of colon cancer or polyps, or some other condition that puts them in the high-risk category, and that should be your primary diagnosis. If the patient is seen prior to a colonoscopy with no signs of symptoms, can you use V76.51 as a diagnosis to support the evaluation and management service? No, you cannot. V codes do not support an evaluation and management code. That service, unless the patient were high risk and required intervention, would not be a billable service to anyone, not just Medicare, but any insurance company using an evaluation and management code. What will be the chief complaint if the patient is being asked to come back for an endo follow-up? The chief complaint would be the reason why the patient received the endoscopy in the first place. So if the patient had symptoms that precipitated the endoscopy, that would be the chief complaint when the patient comes back for follow-up. For a screening colon, can we bill 99201 to 99205 or just 99381 to 99404? Again, you cannot bill an evaluation and management code for a service prior to a screening colonoscopy. That service is not billable, again, because you do not meet the documentation requirements of a chief complaint in the history of present illness. If the procedure takes longer than usual or is complicated, how do we bill for that? You can add a 22 modifier to the procedure code. You must submit not only a copy of the procedure report, but you have to submit a separate statement saying why that procedure was more complicated or more difficult and how much additional time it would take. It is likely that when that claim is paid initially, it will be paid at the regular fee, so you may have to submit that claim for review. and it may take longer to get paid. So that is something that should be done very infrequently and only when you feel very strongly that you should get more money because it was significantly more time spent in performing that procedure. And my definition of significantly longer is at least twice as long as it would normally be to do that procedure. If an ERCP, if we're sweeping for stones and nothing was found, you can still bill the sweep with a 52 modifier, indicating that you made the attempt to find stones, but there were no stones found. You would bill for the ERCP with the balloon sweep for the stones with a 52 modifier. Okay, if the patient came in for a screening colonoscopy and the doctor found polyps and did a removal and biopsy, would you still use the screening as the first diagnosis? Yes. Whenever a patient presents for a screening, meaning they have no symptoms, even if a polyp is identified or biopsies taken during that procedure, the primary diagnosis is still the screening. The secondary diagnosis would be the polyp or the lesion. And again, you would link those in box 24E with the number 2 on the same line as the polypectomy or biopsy code for the procedure. Can you bill an E&M code when a patient comes in for Remicade infusion? Unless you have a separately identifiable evaluation and management service, you cannot bill an evaluation and management code. You would bill the infusion and any drugs that you're infusing, but unless the physician or non-physician provider sees the patient for a reason other than just the infusion, you cannot bill an evaluation and management code. Multiple procedures performed to remove one lesion piecemeal. You would bill the highest value procedure. You cannot bill multiple procedures for the removal of one lesion. Do ER visits pay more? ER visits pay more than your subsequent hospital visit codes. How do you bill an office visit during which you discuss the colonoscopy findings and counseling regarding different ways to take out a large polyp? And then if the endoscopic resection is planned, then how do you bill the office visit and repeat colonoscopy? Okay, if the patient comes back following a procedure and there are findings during that procedure, then you would use the findings as the diagnosis to support the evaluation and management code. And that would apply to any endoscopy, whether the patient was originally scheduled for a screening and abnormal findings resulted. You would bill the findings to support the evaluation and management code subsequent to the procedure. What are my rates to come to your office to do a lecture? I would like to discuss that privately. If you call me at 301-941-2639, I'd be happy to discuss that with you. Modifier 59 on a hot biopsy, a snare biopsy. The commercial insurance company is denying the 59 modifier. Unfortunately, private insurance companies are notorious for not recognizing the 59 modifier, and if you're building multiple procedures during the same endoscopy, they in fact may only pay for one. For that situation, I would suggest you send them a copy of Medicare's multiple endoscopy policy or the introduction to the Correct Coding Initiative, the CCI edits, and push it all the way up as far as the medical director. If that doesn't work, I would suggest you send a letter to your state insurance commissioner or Inspector General's office complaining that the insurance company is not following standard billing guidelines, with a copy of that letter sent to the medical director. That usually gets them moving. We are using new and consult codes. We're allowed to visit prior to procedures. Again, that visit is not billable regardless of the diagnosis that you're, the ICD-9 code that you're using. As long as that ICD-9 code is a V code, that visit is not billable. There are some private payers that have been paying for those visits. There are others who had been paying and have asked for the money back. So again, you are not meeting the documentation guidelines if the patient is otherwise healthy and presents with no symptoms. You do not have a chief complaint. You do not have a history of present illness. So you cannot bill an evaluation and management code, whether it's a consult or a new patient visit. Those would not be appropriate for a visit prior to a screening colonoscopy. What is the difference between lifting the lesion in the upper GIT versus the lower GIT? When you say lifting the lesion, you're talking about an injection. For colonoscopy, if you perform an injection for any reason, that injection is separately billable with a polypectomy or biopsy. However, with an upper endoscopy, it is not separately billable. I do not know the logic for that, but that is the way the system is set up. We have heard that CMS implemented the 99281 to 85 codes reserved for ED physicians. That is not true. In January, when the consultation codes were eliminated, the instructions were that any service, any provider seeing the patient in the emergency room can bill the emergency room visit codes. Why do you feel you cannot dictate all positive systems with ROS and then state all other systems negative in order to get all points for the review of systems? Medicare and other payers have indicated that unless you indicate or you document what systems were reviewed, you will not get credit for any systems that are not listed. When I look at a medical record, if it says all of the systems negative, I do not know what systems you're referring to. So I need to know exactly what systems were reviewed in order to give you credit for those systems. And the same applies to anyone else who audits charts. What if the patient comes into the office for a screening and the physician finds a problem? Can we bill for the visit? If the problem is significant enough to support a diagnostic colonoscopy, then you can bill a new patient or established patient visit with the diagnosis for that problem. But if the problem is insignificant, then the visit is still not billable. Okay, we're going to I'm going to go through a few more questions. We're now exceeded our hour time, but I'll try to get a few more questions in. What if the chief complaint says follow up, but it's easy to infer from anything else that's written there? It's not sufficient. The chief complaint must indicate follow-up for what purpose. When an auditor looks at the chart, they're not going to try to determine based on other visits or the documentation beyond the chief complaint what the reason was for that visit. It must be clear in the chief complaint. If the patient presents for screening but the doctor removes the polyp, does it become medical, and do we code it medical colon or a screening? Again, you would code the procedure code as the polypectomy or biopsy, but the primary diagnosis is still the screening and the secondary diagnosis would be the polyp. My email address for questions is gianswerline@gastro.org, or you can send it directly to me, which is the email that is on your screen right now, ckatsoff@gastro.org. Have you heard about any guidelines for office-based surgical suite billing for New York State? New York State requires that you be accredited in order to do procedures in your office, and you must get accreditation from one of the accepted organizations like the Joint Commission or the American Association of Ambulatory Endoscopy Suite Centers, or ambulatory AAAHC. You can get their requirements from contacting them. We do have a policies and procedures manual available for purchase through the AGA that goes through the basic requirements for office-based endoscopy to meet accreditation. You can purchase that on our website at www.gastro.org. Do you have to have a pathological diagnosis of polyp, or can you take patient's word for procedures done elsewhere? If the patient tells you that they have a previous history of polyps during previous procedures, you can use that as a diagnosis without having any documentation to support that. If a patient only comes in for test results, what code will you bill? Again, if you use the counseling or coordination of care option for the evaluation and management codes, you would code based on the total face-to-face time spent with the patient going over those test results, assuming that happened with a provider. If it happens with a nurse, you would only bill a level 1. The only service that can be billed for a nurse providing the service, which is a 99211, established patient visit at level 1. Okay, normal time for colonoscopy and EGD, that I'm not going to tell you. You can find that out on the CMS website, and that is based on the relative value units used to determine the payment for that code. Okay, I think we're going to have to stop here. For those of you that did not get your question answered, please contact me at ckatsoff@gastro.org. Again, for a more in-depth coding session, you might consider going to the 1 or 2 day sessions given by McVeigh Associates, and you can find the schedule on mcveigh.com or on the AGA website if you look at the meetings section, and that's gastro.org. If you want me to come to your office to give you a personalized training session, please call me or email me, and my contact information is on the slide in front of you. I thank you all for participating. And again, for those of you that want a copy of the presentation, or if you haven't, if someone in your office hasn't had the opportunity to listen in, the webinar will be available on our website within a week. Check back about a week from now, and you should be able to view it that way. Thank you very much.